Okay, we're going to have a little QA. It's on the schedule. We'll probably not do the cases. We'll just go ahead and answer some questions, and then we'll go for lunch.
Yeah, phenomenal talks. I wanted to ask one for the panel, particularly Dr. Zoghbi as well, in regards to, and then a question to Dr. Reardon. The first one is in regards to the concept of PPM for TAVR. The trouble that I struggle with is that first it was derived for surgical prosthesis, and then now we're translating that into transcatheter, particularly for supravalvular prosthesis, where performance is so much better. We use the same cutoffs and we don't take into account gradients. So how to resolve that? Because I cannot conceive, especially the measurement of the LVOT annulus, which is so problematic that can make a big difference. The second question for Dr. Reardon is in regards to asymptomatic patients with severe AS. What are your thoughts on, particularly born on the concept that Dr. Garb has shown to us for mitral regurgitation? We're waiting for patients to become symptomatic, but now they already have AFib, they already have pulmonary hypertension. Could this be new frontiers that we could move the needle forward?
I'll answer the prosthesis patient mismatch. Remember, where's the concept coming from? The concept came originally many years ago from Dr. Rahimtullah, thinking that we have a surgical valve that has a high gradient, and you look as to why it's high gradient. The surgeon wasn't able to put a large valve before expanding the annulus or whatever it is. So you're left with still a pressure overload on this ventricle if it is in the aortic position, and most of them are in the aortic position because the valve is small compared to a mitral position. It doesn't mean that it doesn't occur in the mitral, particularly if the annulus is small because of heavy calcifications, right? Then we found out that, so the high output situation in these patients usually is because of body habitus. More muscle, more high output, as opposed to fat, right? As the population is changing for whatever reason, because fat doesn't have a high output. So you have very low output for fat. And what the definitions of prosthesis mismatch have been is I divide whatever this number by body surface area, which takes care basically of your surface area, but not the actual demand. So this is the fallacy of just dividing without thinking twice. And the reason for it is if ultimately the outcome of these patient prosthesis mismatch is remainder of hypertrophy of a ventricle that should have regressed, or a poor outcome, you have to take a look at that. So the people that popularized this actually looked at one point in time in circulation a few years ago, looking at body mass index as opposed to, and unless the body mass index is normal with a body surface area that is large, the prognosis was affected. But if basically you have a lot of fat, you should not divide by body surface area alone. So bottom line is extrapolating it to percutaneous valve is a bit difficult. Only think about it when the gradient is elevated. Then you could use whatever it is. You could divide conceivably by height square. By other thing, think about BMI in addition to body surface area, so we're not falling into the trap of the changing population demographics.
Before I move on, then I'm going to more comment on Rahimtullah's work. It's really interesting to go back and read his original work, because the original definition of patient prosthetic mismatch is any valve that didn't match normal aortic valve size, which of course is every valve. And if you go back and look, he generates this really interesting graph that shows EOA versus gradient. And most surgical valves fall in that 1 to 2 gray box that he puts in there. But that's at normal flow. What they never show you is what happens when you try to exercise, which moves that curve up and to the left. Unless you have an EOA of 2 or above, your gradient rises very rapidly with exercise. So as we move into lower risk, this is another one of the questions, because we're used to looking at people at rest. And if you want younger people, they really need an EOA of 2 or bigger. That's why anytime I put an aortic valve in you, I stented an aortic valve, I have shortened your lifespan. And the younger you are when I put it in, the more years I've taken away from your life. It's an issue. Asymptomatic AS, there's a saying that the most common cause of death in asymptomatic AS is surgeons. And that can be true. We know you tend to do very well, but there's also some growing data that, if we fix you earlier, as long as you survive your procedure, you're going to do better over the long haul, as long as we don't do anything bad like add PVL or a pacemaker or something else that may impact your life. Because it makes sense. None of us would choose to have AS, even moderate AS, right? or MR, even moderate. I mean, we don't treat these people with that, but it's still not a good thing to have over the long haul. So there are some trials now, of course, that are looking at that, and with Medtronic, we're looking at where we're going to spend our next bucks. I've told them I'll run any trial they'll pay for, and they have not gone for every trial I've suggested. And so right now we're really going to look at moderate AS with heart failure and bicuspid valves, but asymptomatic AS is in the low-risk trial. But to get it, you have to have Catherine Otto's 5-meter jet.
Okay, you want to address some questions before?
Yeah,
I would
let's,
say another 5 minutes or so.
Okay. Number 2 is easy. What's the role of CT and TMVR planning? The role is huge. It's basically the patient selection is based on echo, but all of the sizing of the device, the discussions around the aortic mitral angle, the predictions of the projections of the LVOT obstruction, if any, that's currently all CT based. So CT has a huge role in TMVR planning. Maybe Vera, do you want to look at number 3? Projected AVA and low flow AS?
Yeah, I mean, that's one of the techniques that Pivaro has proposed for trying to reconcile if a valve that in a low flow state to try to reconcile if it's true versus pseudo-aortic stenosis. So it's certainly a viable way to do it. Other ways that you can get to the same answer is to do a dobutamine stress echo, where you get more physiological data. And you can also look at the degree of calcification on a CT scan. So if there's extensive calcification, and there are cutoff points that have been published that are actually different for men and women, so you have to be cognizant of the gender of your patient to be able to get to the same answer. So multiple ways to address the same conundrum of is this true versus pseudo-aortic stenosis. I also can comment on the next situation of experience using moderate sedation for TAVR. This is something that we have transitioned to in our institution, where the majority of our TAVRs are done, and not just low-risk patients. Pretty much almost all of our TAVRs are now done with moderate sedation and transthoracic echo. And we do a transthoracic echo at the end of the procedure, so it's not during the procedure. Most of the time now, the interventionists are using fluoroscopy to guide deployment of the valve. And with the newer generation valves, as well as the increased experience of our operators, the amount of patients with paravalvular regurgitation has really significantly dropped. And that's allowed us to move on to moderate sedation with transthoracic echo. When there is a question of a more than mild paravalvular leak that may require a re-balloon or a re-intervention in the lab, a lot of times the interventionalist is doing an aortogram to confirm. And if necessary, we have the capability of putting in a TEE probe right away and imaging to get better quantification, particularly if the patient is unstable. But fortunately, as our valves have improved and as our experiences have improved, the amount of times where some sort of intervention is needed to correct a paravalvular leak has decreased so much that it's not necessary to do TEEs on all of these patients. So transthoracic echo is it for us.
Our experience is very similar. We're at 95% now?
No, we've backed off from it. I'd love to debate you on that. Centers usually have, what's a polite way of saying pissing contests, Steve?
You said it just fine.
Yeah. We debate. Everyone likes to say they use more moderate sedation, that they're more minimalist. It really depends on your anesthesia group. All our patients are extubated well before they leave the OR. Whether we use, when we use general anesthesia. Frankly, I don't like to tell the anesthesiologist, look, this patient's moving around, it's distracting. For low-risk patients, we, in general, particularly in the low-risk trial, have been very hesitant to use moderate sedation rather than general anesthesia because we want the transesophageal echo and because in a patient who's got a 10-year horizon, we don't want to leave with any paravalvular leak. So, you know, there's a movement very much toward moderate sedation. I think with good anesthesia, there's going to be some pushback.
Dr. Goldstein?
Yeah, we strongly prefer moderate sedation even if TEE is needed. Patients tolerate TEE beautifully. We've been doing it since 1989. I've done almost 1,000 mitral stenotics with balloon mitral valvuloplasty, mean time of TE probe 61 minutes, and we feel it's actually safer in the patients who don't need general anesthesia, and we let the anesthesiologist make that decision.
So I think that question hits on a topic that is debated quite often
Yeah.
still, so there's no short answer for that one.
And I think a lot, as was already stated, it really depends on the specifics of the institution. I don't think that it's fair for us to make a blanket statement for every institution in the entire world to do things the same way. It depends on the level of experience. If an institution is new to TAVR and is just at the beginning of doing it, probably TEE makes more sense because you have to learn how to do the procedure. And it's only as the experience grows in that particular institution that you can even think about moving on to doing something like transthoracic echo. And I also, emphasize that when you go in to do a transthoracic echo at the end of the case, it's not just popping the probe in one position of the chest and saying, looks good, see you later. It really requires an experienced sonographer. It requires a protocol with good sweeps at every single view. Because remember that these valves, it's not a native valve anymore. You have this bulky prosthesis with oftentimes with a stent, depending on the valve, and the regurgitation may not be really easy to find. It may require really sweeping up and down, moving side to side, and really doing a comprehensive assessment in multiple views, which is extremely challenging with a patient flat on their back on the cath table.
Including apical views.
Including
You're
apical
gonna
views.
miss quite a few of the, I mean.
Yes,
and-
it has to be done in every single view, and it has to be sweeps in every single view. So that requires a lot of experience. So that's why you can't make a blanket statement, and if you're going to choose to go through this route, you have to really have good sonographers, a good protocol, and also the capability of quickly moving on to a TEE if either imaging can't be done or a problem is identified.
Let me ask a question to Neal, Steve, and Mike. Moderate to severe MACC. What do you do?
Run.
Thank you. Neal, what are you all doing?
Well, I've got Steve on speed dial. The moderate to severe MACC, my biggest concern is why is this patient symptomatic? Why is this patient dyspneic? Why is their pulmonary artery pressure elevated? Is it because they've got enough mitral valve disease that we're not recognizing it, in which case changing out an aortic valve may not be particularly beneficial? Or is the calcification truly annular? Is it going to be a little bit of a problem in valve expansion, but if we get by without much paravalvular leak, is this patient going to feel better?
Randy, you're talking specifically during TAVR, is that right, or just in general?
I'm talking about the
Addressing
approach
it.
to those patients. So
Yeah.
they come in, they're symptomatic, they've got a mean grading of 9 or 10 across there, or 8, and they've got MR. And so what's your mitral approach to MACC?
So, I mean, the first step is to try to figure out, is that
Refer
causing?
to Gerald.
Yeah.
Refer to Gerald.
The
But
first,
that's exactly what happens,
ping
actually.
pong. I mean, the reality is that the phenotype who gets that tends to be the little old lady.
Okay.
That's the small ventricle. It's the people who have, diastolic dysfunction, big atria, atrial arrhythmia. So it's often very difficult to determine how much is the MACC and how much is the ventricle below the MACC, because they're often in the same person.
Yeah, because it becomes problematic, obviously, in the size of the valve, but the transeptal ASD that you create now becomes also problematic and all that stuff. So it's a difficult issue, I know.
I think we're waiting for
I just wondered what you all are doing here.
We're waiting for the device.
So right now, as you know, Maya Guerrero has her trial, and we're not part of that. I don't know why Ted didn't get me in there, but that's a whole separate issue. and we're getting ready to join the Citral trial, which is the surgical transatrial S3 in there that Bill Brinkman's running with Mike Mack's group, and that's kind of working our way. I mean, there isn't a really good surgical approach to these people, and so what we're looking for is a IRB protocol that we're going to do it in a standardized way. Because if I do this and a few of these fail, I don't want people going, why'd you even touch them? We need an answer. We have these people that keep coming back and back and back to clinic, and there isn't a good answer, and I want somebody to put a transcatheter valve in them, somebody wants me to operate on them, and I don't want to operate on them because the failure rate is just so high.
Bill, why don't you take the TE question, the very first one?
I think that would be the last question we'll answer here. Role of TE in obese patients for evaluation of aortic stenosis. We talked a lot today about transthoracic. You need to use all the windows on thoracic. I mean, obesity may not necessarily affect your signal. So you have to kind of, it's not like everybody who's obese, depending where the obesity is and everything else. And even in obese patients, you can still record the jet in vast majority. And here is, if I'm not happy with the recording of the jet, what else do I do? TEE is not your next best bet nowadays that we have other things. Why? Because TEE will give you two things. One, you take a look at the valve, and usually they're calcific. We're not dealing about rheumatic aortic stenosis here, and there's blooming artifact. If it is opening, fine and dandy, not an issue. But if you're really concerned about aortic stenosis, how severe it is, it's moderate and it could be more, you need much more hemodynamic evaluation. So yes, you could trace it, but it will give you an anatomic area that you and I may trace very differently because of blooming artifact. The only window that you could have is transgastric, and then you are, for recording of the jet, unless it's very high, it doesn't tell you anything because you are limited with angulation. So if I'm concerned about just maybe mild and I'm really not sure, you could do a TE. But if I'm concerned about moderate or more, meaning I need to differentiate that, TE is not your best bet. You do next, most likely CMR if you have it, and the reason for it is you can measure the area and also get the hemodynamics at the same time. So you can get the gradient, you can get valve area, everything else. If you do CT, you're gonna get only the measurement. And that measurement, may not tell you the whole story, particularly if you have low flow situations, etc. So from there, CMR would be your best. And remember, if you don't have either, you can't forget about hemodynamics and the catheterization laboratory. They're always there. It's not like, yes, we're completely non-invasive. If you need it, use it.
Bill, what do you think about contrast? In some technically limited echoes, you may not be able to get a really good signal.
You have an expert close to you on the left side here on contrast.
So we have a study we're just about to submit on that. You're looking at about 150 patients, and those who got DEFINITY, and asking the question, if they got DEFINITY for LV opacification and you do the CW across the aortic valve before and after DEFINITY, what's the impact? And we also paired that with an in vitro study using 3D printed aortic valves as kind of a reference standard. The bottom line is that if you've got a complete AS jet that looks good at baseline, it becomes less accurate if you add DEFINITY or any a contrast agent. Yeah, you really can't beat the accuracy of a good quality non-contrast Doppler signal. Now, if your AS jet, if your CW is incomplete, then DEFINITY gives you a little bit, makes it more complete.
So
It's very similar to the TR jet. So
Steve,
why do you use both?
what's an incomplete jet?
So you can't tell where the peak is. It's sort of, you see roughly the width of the jet, but you really don't have any certainty where the peak is. Probably you could fix it with a better angle if you could. If your angles are limited and you simply cannot, through the best attempts and right peristernal and everything else, you really can't fill in that jet, that's where DEFINITY would have a role, but it's pretty limited.
So, like in this obese patient that is being referred to here, say there was an incomplete jet.
So
could you
yeah.
possibly do a contrast echo before moving on to CT?
So you'd probably do the contrast echo anyway, because you probably want the LV, and you're not gonna see two of the segments, so from any view. So yes, that's an indication for LV opacification, and then it makes sense if you've got an incomplete jet and you're suspicious of AS, then put a CW across post DEFINITY. With all the same caveats, though, the LV has to look good, the DEFINITY has to be well distributed. It can't be the initial bolus, because that'll give you an insane CW jet. So cautious use, I would say.
All right. Well, I think I can smell the barbecue out there. So so bring your lunch here, and then we'll take it in the afternoon.